Good afternoon. My name is Wee Chung. I am from the University of North Carolina, and I'm going to be talking about Doppler ultrasound of the liver and portal hypertension. Doppler ultrasound of the liver and portal hypertension. Technical factors. In portal hypertension, the portal vein may have slow or reverse flow or may be thrombosed. Detection of slow flow requires optimizing Doppler parameters. This involves setting the focal zone at the level of the portal vein, minimizing the wall filter. On the right, we have images of the wall filter set at a high setting and a low setting. The wall filter basically eliminates all the low frequency signals. So when you have a high wall filter, this black band here represents the low frequency signals that have been suppressed. Since we want to detect slow flow, we do not want a high wall filter, and by changing to a low wall filter, we can see that that black band is removed. There are other factors that can increase the sensitivity that you can do. These include establishing a slow velocity range, creating a small Doppler angle, making the portal vein as superficial as possible by putting the patient in a different position, such as decubitus or scanning intercostally, and finally making the color box as small as possible. All these factors will increase your sensitivity to slow flow. Finally, remember that spectral Doppler is more sensitive than color for slow flow. Aliasing. Aliasing is the artifact that you see in the image on the left here. This is the portal vein, and you see blue and yellow color within the portal vein. Does this represent reversal of flow? It does not. The reason you're seeing blue and yellow color is that the velocity range is above the peak set by the color scale on the left here. So since velocities within the portal vein are greater than 0.3 meters per second, you get a wraparound artifact, and the velocity that are higher than 0.30 meters per second appear as blue or yellow. So this artifact can be eliminated by increasing the velocity range, and we can see that this is the exact same portal vein, and by increasing the velocity to 0.4 meters per second, the false color, blue and yellow color within the portal vein has been eliminated. It's important to recognize aliasing because it will create a false impression of reversed flow. On the right is a grayscale image of a cirrhotic liver. The liver here shows a very nodular contour and a heterogeneous echo pattern. The nodularity is better seen in cirrhosis. The nodularity of cirrhosis is better seen when there is ascites. So this patient has ascites, and the nodular appearance of the liver is clearly seen here. One should look for liver lesions, the presence of collateral vessels, vascular anatomy, and the presence of ascites. If there is no ascites present, one can increase sensitivity for detection of nodularity and abnormal liver parenchyma by evaluating the liver surface with a high-frequency probe. Here, a linear 5 to 10 megahertz probe has been optimized for the near field, and it demonstrates nodularity on the liver surface as well as a heterogeneous echo pattern consistent with cirrhosis. The normal Doppler of the portal vein increases postprandially, increases when supine, and has a velocity of between 20 to 30 centimeters per second. Flow is hepatopetal with mild phasicity. So in this Doppler image, the cursor has been placed over the main portal vein, and you have a velocity of 0.27 meters per second or 27 centimeters per second. Flow in the portal vein is laminar in the mid-portal vein. That is to say, it is faster in the center of the vessel than along the periphery. But as the portal vein approaches the porta hepatis, it tends to flow in a somewhat helical manner, like a spiral staircase. And this will create an appearance like you see on the right side. You'll see red and blue here in a kind of braided appearance as the blood spirals its way up into the liver. This helical flow pattern is normal, but it becomes accentuated in the presence of portal hypertension following liver transplant and post-TIPS. So here's an example of the helical flow pattern within the intrahepatic portal vein past the porta hepatis. You see red and blue. The blue in this case does not represent reversal of flow. It just represents the blood spiraling upwards into the liver. The normal hepatic vein waveform is triphasic. It is composed of a S wave and D wave in the antegrade direction, and the hepatic vein antegrade flow is away from the transducer and therefore below the baseline. Then when the right atrium contracts, it sends a spike of reversed flow known as the A wave. So the normal hepatic vein waveform is said to be triphasic. 2 forward spikes of flow and 1 reversed spike here. That means that during ventricular systole, flow in the hepatic vein will be antegrade and will appear blue as it flows away from the transducer towards the IVC posteriorly. But when the right atrium contracts, you will get a spike of reverse flow. So reversal of flow during the cardiac cycle is normal in the hepatic vein. Loss of the phasic pattern in the hepatic vein is abnormal. On the right here, we see an image of a hepatic vein waveform which is monophasic. The normal S and D waveforms and reverse spike of flow in the or A wave are not present. This is a sign of reduced liver compliance and is seen in cirrhosis, where it is considered a poor prognostic sign, and is also seen in infiltrative liver disease. The other cause of loss of phasicity in the hepatic vein is Budd-Chiari syndrome. On the other hand, exaggerated phasicity in the hepatic vein is a sign of congestive cardiac failure or tricuspid incompetence. The forward flow or S to D flow should always be larger than the A or reversed component. In this case, we see forward flow and reverse flow of equal dimension on the Doppler spectrum. This is abnormal and is a sign of heart failure or tricuspid incompetence. This is a color Doppler image on the left and a grayscale image on the right of heart failure. Note that the hepatic veins and IVC are dilated, and that on the color Doppler, the color shifts from red to blue in equal measure. This is a color analog of the waveform that we saw here, where you have forward and reverse flow in equal measure. In cardiac failure, the portal vein waveform can also be abnormal. This patient has congestive cardiac failure, and the exaggerated pulsatility in the hepatic vein has been transmitted into the portal vein. Remember that the normal portal vein flow is always antegrade with mild phasicity. It should never go into reverse, as in this case, where there is a pulsatile portal vein waveform with reverse flow during part of the cardiac cycle. The color Doppler image shows the portal vein flipping from red to blue to red with each cardiac pulsation, and this is a sign of congestive cardiac failure and tricuspid regurgitation. It can also be seen in abnormal flow states such as hereditary hemorrhagic telangiectasia due to high volume, or in arterial portal shunting in cirrhosis. Portal hypertension. This is a video clip of a patient with portal hypertension due to cirrhosis. We see a nodular cirrhotic liver, ascites, and on the color Doppler portion of the image, we see a pulsatile vessel in the liver hilum, as well as a hypoechoic tubular structure posterior to this pulsatile vessel that does not have any flow. So what is this tubular hypoechoic structure. And what is this pulsatile vessel? Well, the pulsatile vessel is actually a hypertrophied hepatic artery. The tubular structure without flow is a thrombosed portal vein. And this patient has a number of features seen in portal hypertension, which we will go over in a little bit more detail. The sonographic signs of portal hypertension are splenomegaly, spleen larger than greater than 12 centimeters, or area greater than 45 square centimeters. Loss of respiratory variation in the SMV and splenic vein caliber. Increased resistance in the hepatic artery, pulsatility index of greater than 1.0. Splenic artery and renal artery resistance also rises. The splenic artery RI rises to greater than 0.6, and the renal artery resistive index is greater than 0.7. The latter can be a sign of hepatorenal syndrome. Hepatorenal syndrome is renal failure developing secondary to renal artery vasoconstriction as a result of portal hypertension. The vasoconstriction in the renal artery leads to activation of the renin-angiotensin syndrome, and this causes renal failure and is known as the hepatorenal syndrome. The hepatic artery hypertrophies in portal hypertension because the body responds by the increased pressure in the portal venous system by sending more blood into the liver through the hepatic artery. So this is a color Doppler clip and a spectral Doppler of a patient with a cirrhotic liver with a large hypertrophied hepatic artery that shows up as this pulsating multicolored vessel, and the portal vein is patent but is almost the same size as the bulked up hepatic artery, and it shows up as this area in red here. It's almost hidden by the strongly pulsatile hepatic artery. Other sonographic signs of portal hypertension are increased in size of the portal vein. The portal vein is measured in grayscale from the inner anterior wall to the inner posterior wall at the crossing point with the hepatic artery, or greater than 2 centimeters from the bifurcation. A portal vein is considered enlarged if it is greater than 1.2 centimeters in diameter. As the portal hypertension worsens, portal vein velocity drops lower and lower, and eventually you reach a stagnant state. Normal portal vein velocity is greater than 0.2 meters per second or 20 centimeters per second. This patient has very slow antegrade flow in the portal vein down to 0.05 meters per second or 5 centimeters per second. And as the velocity drops lower and lower, you reach the stagnant state where you have slow to and fro flow with a little bit of blood going forward and a little bit of blood going retrograde. So this is known as the stagnant or to and fro flow in advanced portal hypertension. As portal hypertension worsens even further, flow starts going into reverse. So this patient has complete reversal of flow. We see that the portal vein is entirely in blue, while the hepatic artery is this multicolored vessel running anterior to it. This is an image of the intrahepatic portal vein in this patient. We see the hepatic artery, which is hypertrophied and in red, while the portal vein running next to it is in blue, indicating complete reversal of flow. So reversed flow in the portal vein is a sign of severe portal hypertension. Portal vein thrombus. Portal vein thrombus occurs in the setting of portal hypertension due to the slow flow in the portal vein and stagnancy. You can also see portal vein thrombus in acute pancreatitis, in abdominal sepsis, and in tumor invasion from hepatoma, metastases, or pancreatic cancer. Acute thrombus is usually hypoechoic and may be indistinguishable from flowing blood. The portal vein is dilated, and here is a case of acute thrombus of the portal vein, which can appears, the vein itself does not, has very few internal echoes, but the vein is shown to be thrombosed by the absence of color flow. The hepatic artery is the vessel running anterior to the thrombosed portal vein. Eventually, as the thrombus evolves, it becomes chronic, and the portal vein, the thrombosed portal vein, becomes more echogenic. Multiple collateral vessels then develop and run in the bed of the thrombosed portal vein. And this appearance is known as chronic thrombus or cavernous transformation of the portal vein. On the grayscale image here, we see instead of a single hypoechoic vessel running into the liver, we see an echogenic portal vein in which is embedded multiple tubular structures consistent with collateral vessels. And this is the color Doppler image of this patient, showing that the multiple tubular structures are actually small collateral vessels. Varices form at sites of natural portosystemic venous communication. These sites are closed in normal patients, but when portal pressure rises, blood is shunted from the portal circulation into the systemic circulation at these sites of natural portosystemic venous communication. The sites that are visible on sonography are the splenorenal varices, gastroesophageal, gallbladder, recanalization of the umbilical vein, and the coronary vein. The coronary vein is actually the left gastric vein, and it comes off the splenic vein and runs posteriorly. This is a recanalized paraumbilical vein. The recanalized paraumbilical vein arises from the left portal vein. It runs inferiorly in the falciform ligament towards the umbilicus. Eventually, it joins the systemic epigastric veins at the umbilicus, creating a cluster of veins known as a caput medusae. So this grayscale image shows the paraumbilical vein coming off the portal vein, then running anteriorly on this sagittal image towards the umbilicus. Here we are following the recanalized umbilical vein towards the umbilicus. Gastroesophageal varices connect the coronary vein and the azygous vein. On this sagittal clip here, through the left lobe of the liver, we see a cluster of vessels running anterior to the aorta and posterior to the left lobe of the liver. The esophageal hiatus is roughly at this point, and these vessels are large gastroesophageal varices as shown on this color Doppler image. Splenorenal varices are found at the splenic hilum. They appear as a bunch of tortuous veins in the splenic hilum that eventually empty into the renal vein, creating a spontaneous splenorenal shunt. This color Doppler clip demonstrates a bunch of splenic varices emptying into the splenic vein. Portal hypertension can be pre-sinusoidal, that is to say the obstruction to the portal flow occurs proximal to the liver, within the liver from cirrhosis or parenchymal liver disease, or distal to the liver at the level of the hepatic veins. We're now going to talk about pre-sinusoidal portal hypertension, and one of the causes of pre-sinusoidal portal hypertension is liver schistosomiasis, which is one of the most important causes worldwide. Schistosomiasis is caused by a parasite known as a trematode, which lodges in the venules of the mesentery. It lays eggs, and these eggs eventually get trapped in the liver and create a granulomatous reaction. This granulomatous reaction causes fibrosis, and the result is a dense fibrotic reaction forming around the portal vein. This grayscale image shows the portal vein here embedded within an echogenic cuff that surrounds the portal vein and its branches. And the portal vein eventually becomes narrowed by this fibrous reaction, and the obstruction to the portal vein leads to portal hypertension. This appearance of the liver is known as the tortoiseshell liver, as shown on this T2 weighted MRI, where the fibrous bands appear as high signal structures within the liver, somewhat resembling the shell of a tortoise. On this color Doppler image, we see that the portal vein here is occluded, and there's echogenic material surrounding the portal vein on either side, and this is the fibrous reaction. This is the hepatic artery here. Post-sinusoidal portal hypertension is caused by obstruction at the level of the hepatic veins. This is otherwise known as the Budd-Chiari syndrome. The causes of the Budd-Chiari syndrome are, it can be idiopathic, tumor invasion from hepatoma, coagulopathy, pregnancy, and oral contraceptives predispose to hepatic vein obstruction, and rarely from obstructing membranes caused by certain toxins. The sonographic features of Budd-Chiari syndrome are obliteration of the hepatic veins, loss or attenuation of the normal pulsatile pattern, and intrahepatic collateral vessels. Acute hepatic vein thrombosis will appear as in the form of a filling defect. So this is an example of an acute hepatic vein thrombosis. This is the hepatic vein draining into the IVC, and within the hepatic vein we see an echogenic filling defect, which is a clot. However, Budd-Chiari usually presents in the setting of chronic hepatic vein obstruction, and this slide illustrates the appearance of chronic hepatic vein obstruction. On the middle and right hand side we have chronically obstructed hepatic vein. On the left is normal hepatic vein for comparison. So a normal hepatic vein has a hypoechoic lumen, and the wall of the hepatic vein is very thin or imperceptible. The waveform within the hepatic vein is triphasic, with a forward S to D waveform and a small reverse A waveform. This is chronic hepatic vein obstruction, and the vein is markedly narrowed in its luminal diameter, while the wall, which is this echogenic structure next to the lumen, is markedly thickened. This is color Doppler image showing a markedly narrowed hepatic vein with a thick echogenic wall, and the waveform from this vein is monophasic. And this is a grayscale clip of a patient with Budd-Chiari syndrome in the sagittal plane. The caudate lobe is markedly enlarged. This is one of the features of hepatic vein obstruction. You see multiple tortuous tubular structures running through the liver that do not correspond to the normal anatomical hepatic or portal veins. These are portovenous collaterals running from the portal vein to the hepatic veins that have formed as a result of the hepatic vein obstruction. And we see here on this color Doppler clip through the same area that the blood is running through these collateral vessels is blue. That's to say they're running away from the liver surface towards the IVC. So the liver is enlarged, specifically the caudate lobe, and there are multiple intrahepatic collateral veins that do not follow a normal anatomical course, running from the surface of the liver peripherally towards the IVC, and they will appear blue. Hepatic artery stenosis produces a tardus parvus waveform distal to the point of stenosis. On the left is a normal common hepatic artery, and the normal waveform has a sharp upstroke in early systole. The Tardis-Parvus waveform is characterized by a much more gentle upstroke in early systole, a resistive index of less than 0.5, or acceleration time of greater than 80 milliseconds. The acceleration time is the time it takes from the start of systole to the point where it starts to flatten off over here. So in hepatic artery stenosis, the acceleration time, the time it takes to reach maximum velocity, is prolonged. The resistive index is lowered. And in this patient, this waveform was obtained at this point here, marked by this small red arrow. The stenosis is shown by this narrowed area here more proximally, but the Tardis-Parvus waveform is seen distal to the point of stenosis. The portal vein stenosis is caused by post-hepatic resection or an anastomotic stenosis in the context of a liver transplant. The portal vein can also be narrowed in patients with pancreatic cancer. This is a color Doppler clip of a patient with portal vein stenosis. The normal portal vein is here, and we see a marked narrowing or waste form at the point of this red arrow, with an increase in velocity as the blood goes through and aliasing as a result in the post-stenotic area. So we have turbulent post-stenotic flow marked by this blue and yellow area distal to the point of stenosis, which is marked by the red arrow. This is a corresponding angiogram showing a stenosis in the main portal vein. This was an anastomotic stenosis in a patient who had undergone liver transplant. A velocity step-up of 3 to 1 is considered significant for portal vein stenosis. On the left is Doppler spectrum of a patient with a liver transplant showing a marked rise in velocity of greater than 3 times pre-stenosis to the stenotic point, where we see a velocity of greater than 2 meters per second. Beyond the stenosis, the velocity drops again. And on the grayscale image, the stenotic area is clearly shown by this arrow showing the point of narrowing. There is also dilatation of the portal vein distal to the stenosis. Hepatocellular carcinoma can appear as a solitary mass or a multifocal or diffusely infiltrative mass within the liver. It can be of variable echogenicity on sonography, and it's characterized by high flow intratumoral vessels on color Doppler. Portal and hepatic vein invasion are seen. So this is a patient with a large HCC within the liver, and the portal vein here is full of echogenic material, which actually can be seen on this grayscale image, which is invasion of the portal vein by the tumor. This material within the portal vein is actually made up of living tumor. As is shown by this color Doppler image, the arrow points towards the thrombosis within the portal vein, but within the thrombus we can actually see little flecks of color, and that's because this is a living thrombus. It's actually tumor tissue, and what we are seeing here is the tumor vascularity within the living thrombus. An arteriovenous fistula is an abnormal communication between the hepatic artery and the portal vein or hepatic vein. This is a patient with a large arteriovenous fistula caused as a result of liver biopsy. We see this area of abnormal color Doppler with mosaic appearance, multiple colors, and we see a large feeding artery in red here, as well as a draining vein. This is another patient who underwent a liver biopsy, and the grayscale image after the liver biopsy shows an complex, partly solid, partly cystic mass inside the liver. But if we look closely at the cystic portion of the mass, we see that there is some movement within it. So this is not a simple hematoma. And color Doppler here shows a red and blue pattern, which has been described as the yin-yang or Korean flag sign, and this is a sign of a false aneurysm. The red and blue is caused by blood entering the false aneurysm, circulating and swirling around the false aneurysm, and then exiting. So this is a large false aneurysm caused as a result of liver biopsy. This is the corresponding CT image showing the feeding artery and the large false aneurysm. And finally, this was a patient who had had a liver transplant a few days earlier and had abnormal liver function. This was the color Doppler image from the liver hilum, and it shows a very abnormal pattern. We see this vessel here in blue, and we also see that it's very high velocity flow because we see aliasing here. So we see a high velocity vessel with flow heading away from the liver. And we see that the portal vein on the grayscale is markedly dilated. This high velocity vessel is arterial, as you might expect. It's very turbulent with velocities of greater than 3 meters per second. This was an arterial portal fistula. The hepatic artery had fistulized into the portal vein and was sending a jet of arterial blood retrogradely into the portal vein away from the liver. This is shown on the MRI in the form of early opacification of the portal vein during the arterial phase, a markedly dilated portal vein. So in conclusion, Doppler ultrasound findings in cirrhotic portal hypertension include a nodular heterogeneous liver with ascites, enlargement of the spleen greater than 12 centimeters or greater than 45 square centimeters, a hypertrophied hepatic artery with increased resistance, a pulsatility index of greater than 1.0, increased resistance in the splenic artery and renal artery, dilatation of the portal vein greater than 1.2 centimeters, slow flow less than 20 centimeters per second, and then with worsening portal hypertension, stagnant flow, then reverse flow. Additionally, there's an increased incidence of portal vein thrombosis and the development of portosystemic collaterals in the form of varices. The splenic vein and SM vein may also demonstrate dilatation and reversal of flow, as well as loss of respiratory size variation. And the hepatic veins may demonstrate a monophasic or flat waveform. Thank you.